All right, as promised, let's talk about some oxygen delivery devices that we can use to actually give a patient oxygen. So, what are our options here? Well, nasal cannula is going to provide oxygen through the nostrils. Now, to use a nasal cannula on somebody, they must have good ventilation, be able to breathe on their own, and be able to breathe through their nostrils. When we provide somebody a nasal cannula, we're going to set the regulator between 1 to 6 liters per minute of oxygen. Now that's only going to provide between 24 to 44% inspired oxygen concentrations. For a reference point, room air is 21%. So the oxygen we're all breathing right now, assuming we're in a clean air environment, is about 21% oxygen. So that nasal cannula, when you're down around 1 or 2 liters per minute, you're getting, 24%. There's a little bit more oxygen. When we get up to 6 liters per minute, there's, more than double the oxygen than what we're breathing in room air. So we can make some improvements, but it's going to be a small step up from just regular breathing. So we recommend these for patients with oxygen saturation in the lower 90s, especially somebody with COPD. We're going to come back at the end of this presentation and talk a little bit about the hypoxic drive for patients with chronic COPD. But basically, we don't want to get their oxygen levels too high. So if they have an oxygen saturation in the lower 90%, or really any COPD patient, we're probably going to start with the nasal cannula and work our way up so we don't give them too much oxygen. If you have a patient that's actually having difficulty breathing, you're going to skip the nasal cannula and go to something stronger. And we'll talk about those other options as we proceed through here as to what you should do. But nasal cannula is for somebody who's maybe they're feeling a little nauseous or weak or just a little bit not feeling well. But if they're having if they report to you, I'm having trouble breathing, I'm going to blow straight on past the nasal cannula. This is not enough for somebody who's actually having difficulty breathing. Next step up is going to be your non-rebreather. So for the non-rebreather, this is for somebody who's, again, they're still breathing adequately on their own. It's not going to do anything to help them ventilate. All it's going to do is help with respiration by giving them more oxygen each time they breathe in. It's not going to help with actual breathing. It's not going to help move air at all. It's just going to give them a higher concentration of oxygen. So when we hook up our non-rebreather to the regulator, we want to make sure it's adjusted to 10 to 15 liters per minute. So much higher. You may even see some sources saying 12 to 15 liters per minute. The way that you know that you're giving them enough oxygen is, remember, on your non-rebreather, you have this reservoir bag. Each time the person inhales, you don't want this bag to flatten all the way. If this bag is flattening the way you see it here now, where it's completely sucked in with each breath, you need to turn up your oxygen flow. It should be, they should be breathing most of the air out of here, but it should be able to it should stay a little bit inflated between each breath. If it's sucking all the way flat, turn up that flow of oxygen. Now, a non-rebreather provides 60 to 91% inspired oxygen concentrations. That's with a good fit of the mask on the face and everything attached appropriately. So, make sure it's adjusted and all that good stuff. But we can get almost, 91% inspired oxygen. That's pretty good. So we're getting closer to almost breathing in 100% oxygen. This is recommended for somebody who's short of breath and they're ventilating with adequate depth. We can see good chest rise. They're not struggling to breathe. They're not gasping for air and telling you they're really having a hard time. This is somebody who's able to move air on their own. They're not, they can actually move the air. There's just not enough oxygen in it. When you use an non-rebreather, when you first get it out of the bag, a lot of times not a lot of times, always, this bag, this reservoir will be completely flat, like you see it here now, because this one's new. When that happens, you need to put your finger over top of, there's a little one-way valve inside the mask. And we need to put our finger over that valve. And what that'll do is force the oxygen. You can see the oxygen's coming in this little port right here. And when that oxygen comes in, it's going to follow the path of least resistance. When this bag is new and stuck together, that oxygen is going to just force this little flap open and just come straight into the mask, which is good because the person's going to breathe it in. But then when they inhale, there's only a little tiny bit of oxygen that's stored in this mask. We want this whole reservoir bag full of oxygen so that when they inhale, that's when we want this valve to open and we want them to pull through this entire bag so that full breath is going to be all oxygen. So when it's new, we're going to cover up that little valve and that's going to force the oxygen to fill the bag. And then when they inhale, it'll open up that valve to suck the oxygen out. Now, when they exhale, it'll push this valve closed and that will let the bag refill while they're exhaling. And then the other thing that's going to happen is that this one's missing the pieces. It's been used by students a lot, but right here on the outside of the mask, a lot of times there's a little rubber seal right here and they're on each side. you want to make sure those are intact. What that's going to do is when the person exhales, it'll open up. Again, it's a one-way valve, so it'll open up. It'll let them exhale their carbon dioxide and all the things they're breathing out, and it'll let that leave the mask. When they inhale, it'll suck closed. So we're not sucking in that 21% oxygen air from the environment. We're only sucking in air through this one-way valve, which opens when they inhale, to pull air completely from this bag, so it's 91%. Now, again, for all this to work, the mask has to be really nice fitting. So we need it to be pinched on the nose. We need to pull in the straps to get this adjusted to their face. We don't want much air leaking around the mask. We want it to fit as good as we can. Okay, so I think that's everything you really need to know about a non-rebreather. Just make sure you inflate that bag before you put it on them, and then that's how it works. Okay, a bag valve mask. Now we're getting into providing ventilations to a patient. So this is for somebody who's not able to get adequate chest rise on their own. So it could be the things we talked about earlier where there's problems with ventilation. They're choking and their airways occluded or partially occluded. It could be somebody who's having an asthma attack or an allergic reaction, an anaphylactic reaction where their bronchioles are constricted. It could be that they're wearing down. Maybe they just had pulmonary edema and they can breathe fine, but they're starting to get fatigued. And it's really difficult for them to take each breath. And they're not able to breathe on their own. So we need to take over and take that work for them. Now, when you hook up a bag valve mask, just go ahead and crank your regulator to 15 liters per minute. That's going to make sure that you get plenty of oxygen with each use of the BVM. Now, on your BVM, you may find you have two places to connect oxygen. You may have one up here somewhere near the mask. And what that's going to do is just put oxygen straight into the mask. But the more important one to use is here on the back. You'll see there's a nipple to attach the oxygen to the back. That's where you want to attach your high flow oxygen, your 15 liters per minute. What that's going to do is fill this entire bag with oxygen so that when we squeeze this to ventilate the patient, we are actually giving them 100% oxygen, or as you can see here, 90 to 95% oxygen. It's basically however much it's in here and anything else that might be leaking in. Now, if you're wondering what this reservoir on the back is for, it's not like the non-rebreather. We don't have to cover a valve to fill it or anything. It's just an overflow. So basically, if this bag fills all the way up and before we give another breath, that overflow will just backflow into this bag and be ready to refill this bag each time that we squeeze it. So that's kind of optional. So we want to use a BVM for patients that are either not breathing at all, not able to get adequate chest rise, or who are just becoming exhausted from breathing on their own. So just to reiterate, a BVM can be used on a patient who's still breathing on their own. Usually they're going to have either a really slow respiratory rate, or sometimes they may have a really fast respiratory rate, like somebody who's hyperventilating. And we try to use the BVM to slow down their respiratory rate, to try to get them to breathe with us every 5 or 6 seconds instead of breathing so quickly. So if you are using a BVM, you want to give that breath for an adult every 5 to 6 seconds, for a child or infant every 2 to 3 seconds. Now, I usually tell people just go with that upper number because you're probably going to count a little bit faster than you think you are. But count 1 Mississippi, 2 Mississippi, or use a wristwatch and watch that second hand to make sure you're actually going that full, at least 5 seconds for an adult, at least 2 seconds for a child or infant. Okay, now using a BVM in the real world, so I'm kind of referencing this based on what I teach my EMT students. Many of you may have had this experience where you're an EMT student in the class, and part of the testing, at least here in Montana, is that you have to be able to use a BVM by yourself, completely solo. And that's what you do. So throughout the class, we practice it, we make sure you can use a BVM by yourself. And that's kind of all we really talk about. We really stick to that. Now, in the real world, if you only have one partner and there's only 2 of you and your partner's controlling bleeding and doing those kind of things, you may have to use a BVM by yourself. But if you're ever in a situation where there are more rescuers standing around, anytime you possibly can, you should have at least 2 rescuers using a BVM. One example, if you have seen my continuing education class, or if you're going to do that on cardiac, the cardiology, the add-on to CPR event where we talk about pit crew CPR. One of the things that's recommended in one of the CPR pit crew things that I like the best is that the person who's doing running the AED they actually help give the breaths on the BVM. So if you have 3 rescuers, one's doing compressions, one's doing breaths, and the third one is doing the AED. The person who's on the AED is waiting for the breaths, but the person who's giving the breaths, they're actually using both hands on the mask with the head tilt chin lift the whole time. And when it's time to give breaths, they just stay there and hold the airway open. And the person who's on the AED reaches over and squeezes the bag twice. That doesn't waste any time. It helps you get back to your compressions just as quickly or quicker because you know that airway is going to be open. And it ensures you have a good seal with that mask because the person on the airway is using 2 hands on the mask and keeping that head tilted the whole time. So that's even during CPR. If you can have, even the person running the AED can multitask and squeeze that bag, that's how important it is. It's always going to be a lot better. And I know I don't emphasize this in my EMT class because I just want my students to focus mostly on being able to do it by themselves so they can pass that skills test. But in the field, if it's at all possible to have an extra person, you should have that second rescuer doing squeezing the bag while one rescuer holds the mask and maintains that head tilt chin lift. Okay. Again, as I said, adults get a breath every 5 to 6. Children and infants get a breath every 2 to 3 seconds. You want to keep the mask on the face between breaths. And what that's going to do is give a little bit of blow-by oxygen. Remember, that bag is full of oxygen. The reservoir is full of oxygen. So once you get a good seal and you have the head tilted correctly, just maintain that seal. Keep the mask over the face. There's never a need to remove the mask unless you have to get out of the way for somebody to intubate somebody or do something else with the airway. If the BVM is not working, if you can't get breaths in with a BVM, switch to a pocket mask. If you'll remember from your initial training, a pocket mask is actually the most effective way to give ventilations for a couple reasons. One, if you're using a pocket mask, you always have 2 hands on the mask to maintain a good seal because you're using your mouth to give the air and not your other hand. The other reason is because you're controlling the air that you're giving with your lungs. You're going to have more control over your own lungs than squeezing that bag. And then also, of course, remember, we're only giving enough air until we see chest rise. Once you see chest rise, you do not need to give any more air. So that's going to vary from patient to patient as to how much air you need. But most of the time, it's going to be, just until you see chest rise. So most of the time, it's not going to be that full bag, that full BVM. Okay, so up next, I want to show you another way. I'm not suggesting everybody has to do this or that it's the best way, but it's just one more tool to have in your tool bag. So with giving oxygen, with using a BVM by yourself, we've been talking about if you have 2 people, it's ideal that one person holds the mask and one person squeezes the bag. Well, what if you're by yourself? Is there a way you can use 2 hands to hold the mask and then somehow still squeeze the bag? Turns out there are a couple ways. This is a video of me demonstrating what they call the chicken wing method. Ignore my really intense look into the camera. I was trying to make sure that I was in the frame. But you can hold the mask with 2 hands and then basically use a chicken wing. Bring your elbow down on the bag. I'm obviously not going 5 seconds between breaths here. I'm just demonstrating how this looks. You can also put your leg beside the patient and push with your chicken wing into the leg, making sure that head's tilted back, having 2 hands on the mask to maintain the proper seal. So these are both acceptable ways, using this chicken wing or having your leg beside the patient's head and squeezing into there, if you can get good chest rise. So this is something you're going to want to practice before you do it for real in the field. So if you want to give that a shot, that's just another thing you can try out. They call it the chicken wing BVM. So it feels kind of awkward. You'll definitely want to practice it. Okay, remember how I said I was using PowerPoint design tool to choose the backgrounds. So I typed in the most underused airway device in EMS is, and they picked for the background somebody doing a deadlift. So I think they're trying to say something about deadlifts being the most underused, probably exercise routine, but we'll save that for another day. So in my opinion, probably the most underused airway device in the EMS is, if you know what it is, think of it, write it down, see if you're right. So I believe it is, go to the next slide here, CPAP. If you're thinking CPAP, you're right. Continuous positive airway pressure. This is underused probably because it was introduced late, somewhere in the 2012 range is when it was introduced into the Montana standards. The textbooks really didn't catch up with it until even maybe a little bit later than that, somewhere around 2012, 2015. So there's not a ton of information about it for a lot of EMTs in their initial training programs because it's so new. But they using CPAP is going to be one of the things we can do to help a patient that, we used to not be able to help. We used to be like, well, we need ALS, we need an intubation. And now at the BLS level, we can use CPAP and actually give them a better outcome than intubation if it's an option. So when should you be thinking about CPAP? We need to think about, okay, when should this be on my radar? Because it's something I'm not using and I should be using it. When should I be thinking about it? Anytime you grab a BVM, you should be thinking to yourself, could I be using CPAP instead? And the first thing you need to think about are your contraindications. If the patient has low blood pressure, you can't use CPAP. Chest trauma, for the most part, you can't use CPAP, and we'll come back to that in a second. If they're unable to follow commands, you can't use CPAP. If they're breathing slow or like not breathing at all, or they have to be able to follow commands. They have to be fully conscious and following commands. So anything like that, they can't use CPAP. Or if they're vomiting or have a GI bleed and might have possible vomiting, we can't use CPAP. So kind of what is CPAP? It's continuous positive airway pressure. So it's like if you had the biggest BVM in the world and you could just keep squeezing it. That's what CPAP is. It's just going to continuously force air, like when you're squeezing that BVM. If you just could never stop squeezing it, that's what CPAP is. So what are these contraindications? Why are these the case? Well, if somebody has low blood pressure, when you give CPAP, you're pushing a lot of air and extra force into the chest, which is great for pushing air and oxygen across the alveoli, across the membrane, into the bloodstream, into those capillaries. It's going to push that oxygen into the bloodstream, and it's going to help get oxygen even through pulmonary edema or through those tiny little bronchioles that are constricted or whatever the problem is. It's going to force that oxygen into the bloodstream. What it's also going to do is add some extra air pressure buildup into the thoracic cavity. And that extra pressure buildup is going to push on the heart. And if you have a heart that's not pumping well and it's already caused the blood pressure to lower, the CPAP is going to cause it to lower even further. So if they have a low blood pressure, rule out we can't use CPAP. Chest trauma, what we're worried about here is a pneumothorax. If they have a punctured lung, if they have a hole in their lung, a pneumothorax, and we hook them up to CPAP, the air is going to really quickly go out of that hole and inflate the chest cavity, putting tons of pressure on the unhealthy lung, but also the other lung that's not injured and all that kind of stuff, as well as the heart. So if they have a hole in their lung, it's a big no-no. Again, unable to follow commands. Remember, we're squeezing that BVM forever. We're not squeezing it and then relaxing to let them exhale. We're just squeezing and squeezing and squeezing and squeezing. So the patient has to be able to forcefully exhale against that air pressure. So if they're not able to follow commands, they're not going to be able to exhale against it. And for the same reason, if they're not breathing or they're breathing slow, they're not going to be able to exhale against that BVM or against that CPAP. So that's not going to work. And if they're vomiting or have a GI bleed and possibly vomit, if they puke into that CPAP, it's going to force that fluid right down into their lungs. So it cannot be used with anybody who's vomiting. So what is this commonly used for? Congestive heart failure. Remember, with congestive heart failure, the fluid that's not being pumped by the heart is backing up into the lung tissues, causing pulmonary edema. So as I described earlier, it'll just push that oxygen right through that fluid from the alveoli, straight through that fluid right into the blood. So that person can still pick up that oxygen. The other one's COPD, asthma. It'll just force air through those tiny bronchioles. Toxic inhalation. They breathed in carbon monoxide or, something they weren't supposed to be breathing. Near drowning, where they're conscious and they're breathing on their own now, but they have a bunch of fluid in their lungs. We're going to force that fluid back out into the bloodstream or outside of the lungs so they can breathe. Okay, now flail chest, again, with great caution, because flail chest, I'm thinking, oh, they could have a pneumothorax. So if they have a pneumothorax, that's not really going to work. But if they have a flail chest and they're, able to follow all these other, check all these other boxes, then we can use it. Lung infections like pneumonia, it's going to help, again, push those thick secretions out of the way and force that oxygen into the bloodstream. Okay, so what else can we say about CPAP? There's still more. follow the device's instructions for the oxygen flow rate. So every CPAP machine, CPAP is going to be a little different. If you think about the ones that people have at home that they sleep with CPAP, it's different than that. Emergency CPAP usually comes like in a baggie, and it's all just a bunch of pieces that are all disposable, so we can throw the whole thing away. So I use the FlowSafe CPAP device, and on the hose, there's actually a little chart that tells you what the flow rate needs to be to reach a certain amount of pressure for the CPAP. So it's centimeters of water is how we measure that. So on mine, to get above 6 centimeters of water, you need 20 liters per minute. So if you have a typical regulator that only goes up to 15 liters per minute, you're only going to be able to get 3 or 4 centimeters of water, which is not really enough. So you really need to be able to go up to that 20 and 25 liters per minute. So you need a special regulator. So if you're ordering CPAP machines for your department, make sure you have those regulators that are going to match. So how much pressure do we want? Between 5 and 10 centimeters of water. And the between 5 and 10 is going to be a little bit with patient comfort, and but the patient's condition is going to kind of give you a pretty good clue for what you need. So 5 centimeters of water is recommended for asthma, bronchitis, COPD. These conditions all cause the bronchioles to constrict, or it's COPD. We have kind of the elasticity of the lungs is worn out. We're not really able to collapse the lungs all the way, but also those bronchioles are going to be constricted with fluid and things like that. So we're looking at 5 centimeters per water if there's something kind of blocking the air from getting in. I would also put in this category the flail chest. Start with that 5 and see if they're able to tolerate that. You may even start lower and then see if we can get up to 5. Fluid in the lungs. So that would be congestive heart failure or any cause of pulmonary edema. Somebody that has a near drowning, somebody that has pneumonia. Things where there's actually fluid in the lungs that we need to forcefully push that fluid out of the way. We're going to crank this guy all the way up to 10 centimeters of water and get the maximum amount of pressure to push that fluid out of our way so we can get that oxygen through the alveoli and out into the bloodstream. Okay, when I used to teach snowboarding, we had an acronym KISS that meant keep it simple, stupid. And this really applies to CPAP. Keep it simple, stupid. I know I just went through a ton of contraindications and this and that. Keep it simple. Basically with CPAP, if you think it's going to work, put it on the patient. They will either immediately get better, keep them on it, or they'll immediately get worse. Immediately take them off if that happens. In fact, before you even secure it to their head, I would suggest having the patient hold it against their face themselves until they get comfortable with it. And that will allow you to, one, get them comfortable with it so you have plenty of time to get the straps on and kind of talk to them and keep them calm and make sure it's actually making them better. And 2, if they start to deteriorate, it's going to be much quicker to take off if you don't have those straps on yet. So have the patient hold it to their face themselves so they can see that it's going to help them. And once they realize it's going to help them, they won't be worried about the claustrophobia, and they'll be really glad they have that to help them breathe. Okay. Now, if you can't do any of these things, if maybe you have there's a child patient and they're not tolerating a nasal cannula or non-rebreather or a BVM, BVM, if we have to use that, we just have to. But if the nasal cannula and the non-rebreather aren't working for somebody, we always have blow-by oxygen. That's another option. You can just take the hose right off of the non-rebreather and put that basically in front of their face, just so they're getting a little bit better than room air. A little bit of oxygen is going to be better than no oxygen. So kind of keep that in your back pocket as an option if that nasal cannula and non-rebreather aren't working for whatever reason. Okay, we can't really talk about airway without talking about oxygen toxicity a little bit. This is kind of a newer thing in the last 10 years or so that we used in the good old days, we just, more oxygen's better. Just give every patient as much oxygen as you can. How could it hurt? More is better. Well, sometimes too much of a good thing is not always better. And that's the case with oxygen. Basically what happens is our red blood cells carry oxygen. And if we give them too much oxygen and those red blood cells get too full, they can implode, they can explode. And now we have damaged red blood cells, which are going to go out into the body and cause further damage to other tissues in the body. So we don't want to damage those red blood cells. Going further, our bodies are smart. We are really smart mechanisms that protect everything. We have protective mechanisms for everything we can think of. So you have something in your neck called carotid bodies, and these are different from your carotid arteries, but they are related. But these carotid bodies measure your oxygen saturation. And if they detect a high level of oxygen saturation, they will actually constrict blood flow to your brain to protect your brain tissue. Because remember, those damaged red blood cells are going to go into the tissues and cause further damage. So think about what that means. If you give somebody too much oxygen because you're thinking more oxygen, we need to get more oxygen to the brain, they're actually going to get less oxygen to the brain because those blood vessels are going to constrict. Those carotid arteries are going to constrict because the carotid bodies tell them to control blood flow to the brain. So there'll be less blood getting to the brain if there's too much oxygen in it. So we don't want to just blast people with oxygen. We basically want to keep their oxygen saturation around 94% or follow your local protocols. We don't really need to go higher than 94%. If somebody's at 94%, I don't need to blast them with a non-rebreather, right? Now, if they're struggling to breathe and that pulse oximeter is reading 94%, I need to question that pulse oximeter. Something's not adding up here. Okay. This is especially important for stroke patients. Their brain is damaged. They already have a problem with their brain. They already have part of their brain that's not getting enough blood flow. If we blast them with oxygen, thinking, oh, they need more oxygen, remember, we might be reducing blood flow to the brain. So more is not always better. Okay. Now, related to oxygen toxicity, but a little bit different. We have patients with long-term COPD. What happens if somebody has long-term COPD is that, first of all, let's take a step back. In a healthy person, our drive to breathe happens from our brainstem measuring our levels of carbon dioxide. When our brainstem measures we have too much carbon dioxide, we breathe faster to exhale that carbon dioxide off. When our brain detects that we have not enough carbon dioxide, we breathe slower to retain more of that carbon dioxide to get it to a normal level. That's how a healthy person's drive to breathe works. And somebody with long-term COPD, they're always having too much carbon dioxide. Their carbon dioxide levels are always high. So they breathe fast and breathe fast and breathe fast and breathe fast, and they can never bring it down. So they still don't fully understand the science behind this, but essentially what they think happens is that the normal drive to breathe goes, we're done. This is not working. We're breathing as fast as we can, and it's not changing. We're going to give up. Luckily, we have another mechanism that kicks in. It's called the hypoxic drive. And so for these patients with long-term COPD, that hypoxic drive kicks in. And instead of the brainstem measuring levels of carbon dioxide, somebody with COPD and the hypoxic drive measures the level of oxygen to determine how we should breathe, which would be the way we would all guess that it works, right? It feels like, oh, I'm low on oxygen. No, actually what you're feeling is that you're high on carbon dioxide. But anyways, somebody with COPD, they measure, their brain goes, hey, we're low on oxygen. Let's breathe faster. So if their oxygen levels get up to 99%, their body hasn't seen that in decades, their brain goes, bro, we're good. We got tons of oxygen. Let's stop breathing. We'll stop breathing on you. So especially with COPD, you just want to keep them at that minimum threshold, 94%, even 92%. If they're in those lower 90s, we're happy. We just want to keep them right there. Really be thinking about, is nasal cannula enough? If they're at 89%, I'm going to go nasal cannula. Can I get them up to 92? Let's get there and keep it there. Let's be happy. We don't need to blast them with oxygen and get them all the way up to that 99%, because again, they'll stop breathing. Okay, the last thing I want to talk about is kind of unrelated to what we've been talking about, but prone transportation of a patient. So basically don't do it. We don't transport people prone. And the reason I bring this up is because I know during the COVID-19 pandemic, a lot of patients in the hospital were basically they were laid prone, which is face down, to help with breathing. And they use these for these severe COVID-19 patients. But we're not going to do that in the ambulance. And there's several reasons. First of all, it's not going to help. That's something that's done for 12 hours, 18 hours, 24 hours, maybe even multiple days. We're looking at even a really long ambulance transport time of 2 hours. It's not going to make a difference if they're prone or supine. It's not going to help their breathing by putting them prone, even if they're a severe COVID patient. Furthermore, we don't have the appropriate equipment to put somebody prone. When they put somebody prone in the hospital, they have special beds. that have like openings for the face so they can still get oxygen and they can still monitor their airway. They have them hooked up to equipment that's measuring everything. We do not have that in our transportation units. So don't put somebody prone. Basically, you can't monitor their airway, you can't protect their airway, and it would just be really easy to make the situation worse. So if you've read about prone patients, that's a hospital setting use. That's not something we're going to be using in emergency medicine because one, it doesn't work. Two, we don't have the equipment to do it safely. So that's all I have for airway, oxygen, and ventilation. I hope you guys enjoyed this and hope to see you for another continuing education class. Have a good day.